Hi, thank you for joining us. My name is Dr. Reid Lombardo from Mayo Clinic. We're here today with Dr. David Nagorney, and we would like to talk to you about surgical options and treatment for hepatocellular carcinoma. Welcome, David.
Thank you, Kay. I'm glad to be here.
David, you're an expert in this field and world-renowned, and so I want to tap your brain for some things that patient might consider about hepatocellular carcinoma. First of all, we know that it's a primary disease of the liver. Who are at risk for this disease?
Well, primarily people who have chronic liver disease. Anybody who develops cirrhosis, regardless of cause, is an increased risk for liver cell cancer or hepatocellular cancer. There are some other disease processes that can occur, congenital disease processes, but mostly cirrhosis.
And so if patients have cirrhosis, should they be followed to see if they will develop this disease in the future, or should they wait for symptoms to arise?
Most patients should be followed and screened for liver cell cancer. Many programs there has been a screening program which has been developed by imaging the liver and obtaining blood tests to determine if we can find hepatocellular cancer. It's not perfect, but it's the best thing we have to date. So anybody with chronic liver disease on a bi-yearly basis obtains a blood test and an ultrasound of the liver to detect an early liver cell cancer.
So their doctors at home should follow with an ultrasound and blood test. Now, some patients do not have chronic liver disease and develop HCC. And so in terms of those patients, what are the risk factors that they may face?
There's very few risk factors for patients that don't have cirrhosis. There are occasional congenital disease processes, metabolic diseases that can cause liver cell cancer. Women are particularly at risk for liver cell cancer. We know that the use of estrogens, oral contraceptives, can cause liver cell growths, and some of which can turn into liver cell cancers. Otherwise, there's very few things that cause liver cell cancers in a non-cirrhotic patient.
Now, with the increase in incidence of obesity in the United States, we are seeing more patients with a fatty liver, is what we call. There's increased fat deposition in the liver. Are these patients at risk for hepatocellular carcinoma?
Yes, they are. Non-alcoholic steatohepatitis or NASH or any type of fatty liver disease can progress to chronic liver disease. Most of the times the patients who develop cancer with fatty liver disease eventually develop cirrhotic stage disease, but all disease processes that are chronic within the liver can develop liver cell cancer before the cirrhotic stage disease occurs.
Are there any risk factors, or are there any symptoms that are concerning or should alert a patient to go to their primary care doctor to detect whether or not they have a liver cancer?
Liver cell cancer is generally fairly silent until it's advanced. So early presentation of liver cell cancer is very uncommon. Patients can have some mild right upper quadrant pain or upper abdominal pain, some discomfort, but that is uncommon. More often than not, the symptoms and signs of chronic liver disease will appear before the liver tumor can be recognized.
And so some of those symptoms may be ascites or weight loss or even having persistent pain that won't go away.
That's correct.
Now, when you see a patient that's referred, when would you ideally like to see this patient? At what part in the disease process would you as a liver surgeon prefer to see and make treatment recommendations for these patients? Obviously, sometimes we see patients that it's too advanced. So when would you recommend for referring physicians to send patients to see you?
Well, obviously the earliest stage of disease, or the smaller the size of the tumor is best for us to approach, whether it be for a resection standpoint or a liver transplant standpoint. So as soon as a tumor has been recognized, we should see the patient and make a surgical evaluation.
And I want to highlight that fact that as soon as the mass is identified, not to continue following the mass, but to send for a recommendation, correct?
That's correct.
And if you see these patients, do you prefer that they get a biopsy at home, or would you prefer that they come here to be evaluated first at Mayo Clinic?
That's a complex question, but more often than not, we prefer to see the patients first to decide whether a patient needs a biopsy or not. Most of the times with current imaging studies, the degree and accuracy of the imaging studies can tell us for sure whether the patient has a liver cell cancer or not. In only rare circumstances do we need to obtain a biopsy.
Excellent. So now you have a patient in your office, they have a liver mass, and the size is about 3 centimeters. Do you send the patient for surgery and you operate to resect the tumor, or is that patient a candidate for transplant? What I'm getting at is asking you, how do you distinguish who should go for a surgical resection or who should go for transplantation?
The long answer is short. It's a complex algorithm how we decide which treatment alternative a patient pursues. In general, we look at the patient first, the stage of their liver disease from the non-tumor standpoint. So we look at patients who have cirrhosis, and most of these patients have cirrhosis. So we determine whether they have compensated cirrhosis or decompensated cirrhosis.
Can I interrupt you to clarify what that means for our audience? What is compensated and what is uncompensated?
Compensated cirrhosis means that they have bona fide chronic liver disease, cirrhosis, based on biopsy or certain imaging studies, but they have no complications of the cirrhosis. That is, they've had no encephalopathy, they've had no development of fluid or ascites within the abdomen, and they haven't had any bleeding from their chronic liver disease.
Okay. And so patients obviously with those symptoms will have an decompensation of the liver, and so they may be evaluated in a total different way. Correct. Than those who are compensated. Correct. And so for you, what percentage of patients are candidates for surgery?
Not a large percent. Most of the times patients present with advanced disease, so probably less than 10 to 15% of all patients with hepatocellular cancer are actually candidates for operative intervention.
And I asked you a bit of a controversial question before, whether they should go for surgical resection or transplantation, but what is the protocol here at Mayo Clinic?
The protocol is, again, based on the stage of their liver disease and then the stage of their tumor. Once we've decided whether they have compensated or decompensated cirrhosis, they'll follow a track. If they have compensated cirrhosis, then we still would evaluate for possible resection. And whether we pursue a resection or not, or removal of the tumor, it's based on the size of the tumor, the position within the liver, and other factors related to the liver per se. If they have decompensated cirrhosis, then we look at those same factors and then see if they're a candidate for liver transplantation. In general, resection, or taking out part of the liver in patients with cirrhosis, are only indicated in well-compensated patients without signs of portal hypertension and small peripheral tumors. Any other patient that have those issues would follow a transplant route.
So, David, tell us, what can the patient experience when they come into the program for an evaluation of their HCC tumor?
Well, the patients come in with a complex problem, so it requires that they see a number of physicians. The physicians involved in treating patients with liver cell cancer are our hepatologists, our liver transplant surgeons, and the general surgeons who are involved with removing portions of their tumor. Sometimes other physicians are also involved based on their other comorbid conditions, but most of the times those are the three groups that see our patients.
So it's a team approach that the patient will experience when they come here.
Correct.
What are some of the post-operative expectations that a patient can experience?
Most of the times, liver surgery can be very straightforward, so their hospital stay is relatively short. We do liver surgery in two ways. We do laparoscopic liver surgery to take out a portion of the liver, and we do open liver surgery where we make an incision to take out the tumor. Laparoscopic approach, the patient may be in the hospital for maybe 2 to 3 days. If it's an open approach, it's probably 4 or 5 days they stay in the hospital. The extent of liver resection really has little impact on how long they stay in the hospital. Their underlying liver disease has probably a greater impact on how long they stay in the hospital. The liver is quite remarkable because it does grow back after we take out a portion of the liver. Even cirrhotic livers will grow back, though they grow back a little slower. So generally within several months to at least 6 months after surgery, the liver grows back to normal size. So its ability to process foods, toxins, do all the things that a normal liver does, it's capable of doing.
What are some of the alternative treatment options available at Mayo that you may recommend for a patient who's not a candidate for either surgical resection or transplantation?
There are a number of approaches, alternatives to surgery. We have two basic groups of treatments. We have directed treatments to the liver and those that are more systemic in nature. The directed treatments we have to the liver are ablative approaches, which can be done either operatively or percutaneously or through the skin. And then we have ways that we can block the arteries that go to the liver and give chemotherapy directly into these tumors.
And you're describing chemoembolization.
Correct. We give chemotherapy directly into the tumor, and then we block the artery that goes there so that it steals blood supply from the tumor, so it helps kill the tumor itself.
So there are many opportunities for treatment options available at Mayo Clinic if a patient is not a candidate for surgical resection.
Correct.
So David, we touched on the fact that transplantation is also an option for these patients. And so what is the path that they would take, and what are the opportunities there that currently exists at Mayo?
Right. Well, again, patients with liver cancer have chronic underlying liver disease. So any patient who has cirrhosis in a tumor is always considered for transplantation. Depending upon their stage of liver disease, they may be an independent candidate for liver transplantation. As far as the tumor goes, it has to be a certain stage tumor, or what we call a stage 2 tumor. So there has to be a certain number of tumor nodules within the liver of a certain size that would allow them to become a candidate for liver transplantation. The beauty of liver transplantation is that it takes care of the chronic underlying liver disease as well as the tumor, and the outcomes are quite good after transplantation.
This center, along with others, have shown excellent survival outcomes with transplantation for this disease. What about those patients who are not immediate candidates for transplantations? Are there any options available for them?
Yes, some of the patients, or a lot of patients, fall outside the bounds of what we consider transplantable. There are now a variety of protocols that we use to downsize the tumors to make the tumors small enough so that we can then transplant those patients. If we change the tumor size down to the smaller size that we would want to transplant, then their outcomes are just as good. And
what are these methods that you're currently using to shrink the tumors?
most of the times we're using chemoembolization or radiotherapy that we give directly into the liver that downsizes these tumors.
And then reassess these patients for transplantation after.
Correct.
Why should a patient choose a center like Mayo Clinic for their care of HCC?
Well, Mayo Clinic's a high volume center, or one of the top centers that sees chronic liver disease in the United States. And the major centers that see high volume can offer a broad spectrum of treatments that can be more effective for their patients.
And also the outcomes are better because you have a team of physicians and nurses taking care of these patients and helping their outcomes
That's correct.
be better.
Very focused approach.
You have been a top surgeon in this field. And so I want to give you the opportunity to say any additional words for HCC based on your experience.
I think that we just need to know that this is a major problem worldwide, and it's an increasing problem in the United States. With the influx of hepatitis C and other causes of cirrhosis, this is becoming a much more frequent cancer that we need to treat. And we need to emphasize to all people who see these types of tumors to get them to major centers as quickly as possible so we can afford the patients the best chance of survival.
Well, on that note, I want to thank you for your time, David, and thank you for joining us in our discussions of hepatocellular carcinoma.